Welcome. Today's FERNE educational opportunity discusses the dizzy emergency department patient and the GRACE 3 guidelines which come to the rescue of the emergency clinician. My name is Edward Sloan. I'm an emergency physician from Chicago. I'm Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. I'm Medical Director for the Physician Assistant Studies Program at Dominican University, and I'm Medical Director for New Rose Healthcare Management, which helps to staff an emergency department in a safety net hospital on the south side of Chicago. Thank you to the EIM group, the group that initially supported my presentation of this information in December of 2022. I have no financial conflicts. I'm the FERNE President and Board Chair. FERNE has educated emergency clinicians for 2 decades in how to optimize the care of patients with neurological emergencies and injuries. So the ED dizziness patients, what conclusions and recommendations can we come up with? So what are the conclusions that can be made regarding the GRACE 3 guidelines and the ED diagnosis and treatment of dizziness and vertigo patients? In conclusion, there are 3 vertigo types that suggest diagnoses, either peripheral or central. It is possible to distinguish central versus peripheral diagnoses. Neuroimaging is found to be less useful for most vertigo patients. The exam should include the HINTS Plus test when a clinician trained in this testing is available. It's also important to look for anterior and posterior neurological signs and tests that would indicate TIA or stroke. It's important that discharge occur only when specific findings suggest that the patient is safe because the likely etiology of the vertigo is peripheral. The patient must be able to walk out of the emergency department. The documentation is very specific and can be templated. And lastly, consider the GRACE 3 work as a specialty. In other words, beginning to train emergency clinicians in the optimal treatment of patients with vertigo begins with training a subgroup of emergency clinicians who have an interest in neurological emergencies and injuries. What are the recommendations that can be made regarding the GRACE 3 guidelines and the ED diagnosis and treatment of dizziness and vertigo patients? The general recommendations are as follows. Know the 3 vertigo types and diagnoses. Be able to determine a central versus peripheral etiology. Neuroimage only for specific diagnoses. Learn the HINTS Plus test or consult a specialist who has been trained in HINTS Plus testing. Check for hearing loss and ataxia. Check for a middle cerebral artery stroke. Discharge acute vestibular syndrome patients only if the head impulse test suggests vestibular neuritis as the etiology. Have the patient walk out of the emergency department. Document easily through the use of templates related to vertigo. And know that the training should occur globally but can occur optimally to begin with in emergency clinicians who have an interest in neurological illness and injury. So what are some of the detailed recommendations that can be made regarding the GRACE 3 guidelines and the ED diagnosis and treatment of dizziness and vertigo patients? So regarding the 3 vertigo types, know that acute vestibular syndrome is continuous severe vertigo present at the time of emergency evaluation, and know that there are 2 episodic vertigo types, whether spontaneous or triggered. Regarding the determination of a central versus peripheral etiology, we know that nystagmus can suggest a central cause if it is bidirectional fast, rotatory, or vertical. And we know that anterior and posterior stroke signs and symptoms can be detected on a good neurological exam. Learn the HINTS Plus or consult a specialist. We know that the head impulse test being positive on one side is necessary, as is the test of skew to detect either a peripheral or a central cause of the vertigo. Regarding neuroimaging for specific diagnoses, We know that the plain brain CT or non-contrast CT as a test for dizziness is most often not helpful and not indicated. We know that CTA or MRA can be used to look for large vessel occlusion in TIA and or stroke patients who come in with vertigo. And we know that if the HINTS test is not possible or feasible or even equivocal, it may be necessary to do MRI, MRA testing in these vertigo patients. And lastly, checking for hearing loss, ataxia, and pain and temperature sensory loss is essential to exclude a central etiology related to posterior circulation, vascular problems, and insufficiencies. What are more of the detailed recommendations that can be made regarding the GRACE 3 guidelines and the ED diagnosis and treatment of dizziness and vertigo patients? So again, we know to check for middle cerebral artery large vessel occlusion in TIA and stroke patients related to a possible anterior circulation problem. In other words, with weakness or facial droop, altered mental status, or abnormalities in vision, aphasia, or neglect the Van exam, look for a middle cerebral artery large vessel occlusion. Discharge acute vestibular syndrome patients where the head impulse test confirms a peripheral etiology. In other words, you need to have a saccade on one side, bringing the eyes back to the middle, suggesting that one of the two vestibular systems are abnormal or ill. This then proves a peripheral vestibular system etiology. Have the patient walk out of the emergency department. Exclude truncal ataxia and ataxic gait. Truncal ataxia, not being able to sit in the cart. Ataxic gait would be wide-based or unsteady because the patient has cerebellar problems. Document easily with templates. The documents with templates can include acute vestibular syndrome with vestibular neuritis or labyrinthitis. It can include acute vestibular syndrome with suspected central etiology because the HINTS Plus exam is equivocal. And it can include EVS patients with BPPV, that is, triggered episodic vestibular syndrome patients likely related to BPPV. And lastly, there can be a template for nonspecific dizziness when all other etiologies have been excluded. And lastly, know that training should occur globally, but it can begin first with awareness of this GRACE 3 guideline, and it can occur as we develop the means for more broad HINTS Plus use by training specific emergency clinicians interested in vertigo and neurological emergencies, and or training our neurological consultants in this testing before training the broad spectrum of emergency clinicians. For more information, email me at ferne.org@gmail.com. You can go to our ferne.org website or find us at ferne.org on our social media. We have this content posted on our YouTube channel, and it's available in the small 1-minute lectures on TikTok and Instagram. You can also find us on X, Facebook, and LinkedIn. Thank you for your participation in this educational opportunity today.